Hello class, I'm going to just do a summary of chapter 29 in your IGGY book, 8th edition, on care of patients with non-infectious upper respiratory problems. So I hope this helps you to kind of see what I think are the most important aspects of the chapter. A lot of these things will be somewhat of a review for you, so if you have any questions after this, please let me know. Okay. This next slide just shows you somewhat of the anatomy, and when we talk about the problems or diseases with this part of the respiratory structures, we're referring to the nose, the sinuses, the oral pharynx, the larynx, and the tracheo. And we're going to look at some acute as well as some chronic problems that you may see with these particular structures in the respiratory system. Since we are talking about the upper airway anatomy, the one thing we always want to keep in mind is to be sure that the patient has a patent airway. So we are assessing proper gas exchange. And some of these problems or diseases that we may see, some may be somewhat minor, while others may be very, very serious, which truly impairs airway flow and causing your patients to, become hypoxic and later suffer some very serious consequences. These are just showing you those upper airway structures that I just mentioned, and obviously this slide is extremely important to always remember this, and particularly embedded in your brain about our major nursing priority is with diseases and disorders of the upper respiratory tract is definitely to promote oxygenation by ensuring that the patient has a patent airway. Okay. Some of these things that we're going to talk about really will not see a patient become a admission to a hospital, but some of these things may cause the patient to have to make a visit to the ER, and depending on the severity of the trauma or injury to that particular structure will determine whether or not these patients should be admitted, because our concern is that many of these injuries are not life-threatening in themselves, but they can later on impair airflow and cause that upper respiratory system to become obstructed, especially when we have bleeding or we have any type of swelling or edema occurring because of the severity of the injury. And the first thing we're going to talk about is fractures of the nose. And this is, any type of injury that we may see to this particular area that may incorporate somebody falling, some kind of sports accident, or even some kind of auto accident where there is some minor trauma involved. And obviously, with a fracture of the nose, the displacement of either the bone or cartilage of the nose can actually cause airway obstruction, or even later on a cosmetic deformity, and can actually be a potential source of infection. And fracture of the nose are probably one of the most common facial fractures that we see, probably one of the most common fractures in the body. And as I said before, it can be usually the result from a direct assault on that particular area. And obviously, the initial signs and symptoms are it's going to hurt a lot. Pain. As I said before, signs and symptoms of these types of injuries and fractures to the nose, a patient may manifest pain, obviously. They can have bleeding externally and internally in the pharynx. One thing you'll probably notice is swelling of soft tissues adjacent to the nose. Sometimes we see periorbital ecchymosis with at times nasal obstruction, and some of these real severe fractures will actually cause a deformity. It's really important too, when these fractures occur, that you want to assess any type of drainage that is coming from one or both of the nares as a result of this fracture. Sometimes you may note some blood or clear fluid. That clear fluid may be cerebral spinal fluid, and it usually rarely drains from one or both nares from just a simple fracture. But if it is present, it could indicate that you've got a more serious injury going on, particularly a skull fracture. And that's what you have to always kind of keep in mind. You may see that visible injury to the nose, but think the proximity of where the nose is that you want to also keep in mind to continually assess your patient for any neuro problems, assessing their neural function, because along with that nasal fracture, the patient could have either suffered some kind of trauma to the head or even to the facial bones, which could really see manifestations develop, maybe not immediately, but later on. But you always have to keep that in the back of your mind, that that is a potential for a more serious injury, along with just a fracture of the nose. And just keep in mind too, when we see this type of drainage, you want to ask yourself, well, how do I know if it is cerebral spinal fluid? Because it will be somewhat different from normal nasal secretions, meaning that CSF contains glucose, which will test positive with a dipstick. And when CSF dries on a piece of filter paper, what you see is a yellow halo will appear as a ring on that dried edge of the fluid. And you can't just go by x-rays alone, because they're not always helpful in making that diagnosis with a simple nasal fracture. Okay, so just keep that in mind. And usually if the bone or the cartilage is not displaced, serious complications usually do not result, and sometimes treatment isn't even needed. So many times when these injuries occur, the person doesn't even have to go to the emergency room. Just to help reduce a lot of the swelling, you might want to just put cold compresses on the area and give some kind of over-the-counter pain relief, primarily Tylenol. Be careful of your Motrins, because they can cause further bleeding. So that's things you want to keep in mind. The next type of injury would be a closed reduction, which is more of trying to manipulate the bones by palpation to actually put them in their proper alignment. This would be a much more serious injury to the nose. Either a local or general anesthesia may be given to the patient, obviously depending on their health history, their age. And usually it's done in the first 24 hours after injury, because the concern is edema and the formation of scar tissue. That's what we mean by a closed reduction of that fracture of the nose. And as I said, a patient, as long as there's no compromise of their respiratory status, they'll be sent home, and again, instructing the person to continue with cold compresses to decrease the swelling and just give some kind of pain treatments, because when that anesthesia wears off, that person is going to feel a lot of discomfort in that particular area. And again, that initial injury, to determine exactly the treatment for that, will really require a good assessment at the site of the injury, looking for any deviation, any malalignments, or even any change in the nasal breathing will determine how extensive or how aggressive that particular treatment is going to be. The next one is rhinoplasty, And what this basically is a surgical reconstruction of the nose for cosmetic purposes. And I think you might know it better by a nose job, and many times it's to also help improve airflow. And this surgery may be also performed for reduction for severe fractures, or for even some of those fractures of the nose that have not healed properly, okay? And your book, brings about a very good picture of the type of dressings and what the patient will look like when he comes out of surgery. As you can see, I'm showing you this on the screen right now, and this is what you would see with your patient, a rhinoplasty. There'll be packing in the nose to prevent bleeding. It also provides support, and that packing will be in both nostrils. Many times they'll put an antibiotic ointment with gauze, and you can see where the patient also has a drip pad under the nose to assess for any type of drainage, assess the color, and again, to kind of see what kind of drainage that is. Is that just regular nasal secretions, or is this cerebral spinal fluid? Obviously, with this type of packing and dressings, the patient will now definitely be a mouth breather, because they're probably not going to be able to pass any air through the nares. And our big concern with this type of patient is to assess for any serious edema, and obviously for bleeding. And the question is, you ask yourself, how can I tell if this person is bleeding? We want to assess how often a patient swallows, because that is a priority. Because what is happening is that blood is dripping down in the back of the throat. The patient is feeling that, and what he will constantly do is continue to swallow so he can breathe. So if you see that, and even assess for that, that would indicate a posterior nasal bleeding. And many times, to verify that, you might want to take your pen light and actually have the patient open their mouth and look in that posterior part of the oral cavity, and you will see that the bleeding is occurring. You need to call the doctor immediately, because if the patient is bleeding in this regards, it pretty much is a emergency, okay? Obviously, you're going to assess the patient's vital signs until the patient is discharged. And if they feel that the patient will have an uncomplicated rhinoplasty, they'll be discharged the day of surgery. And again, it's very important that they receive proper discharge instructions about what they are allowed to do and what they should not do to prevent any bleeding or additional damage to the area. And what we might tell that patient is just have their head of the bed up in a semi-Fowler's position, and to just move slowly. No need to make sudden and quick jerking motions. Just encourage rest and cool compresses to decrease the swelling and bruising. Maybe soft foods. Just make sure the patient has had their gag reflex returned. Make sure they're getting a lot of fluids a day, at least 2,500 milliliters a day, as long as they don't have any other history of chronic diseases that deny them unlimited amount of fluid. Definitely avoid coughing and straining, and that's pretty obvious as to why. And actually no sniffing upward or blowing the nose. And if they have to sneeze, encourage them to remember to open their mouth to prevent increased pressure in that area. No straining with bowel movements, so laxatives or stool softeners may be recommended, and definitely no aspirin or NSAIDs. Some of these patients, depending on the severity of the injury, may be on antibiotics to prevent any type of infection, and a lot of times these patients get really dry, so a humidifier may help them, especially in the first few days after surgery. With a uncomplicated rhinoplasty in which a patient does go home, it's very important to tell these people that they may not see any final results from the surgery for about 6 to 12 months post-op. So it's very important, so they're not thinking that in a few weeks everything's going to look just perfectly. That unfortunately is not the case. These patients will have a lot of edema that may last for weeks, so they need to be aware of that so they don't think that anything is wrong. And again, the important thing with this type of surgery is the concern for posterior bleeding. So in order to assess that, we would just see if the patient swallows after nasal surgery, and if it is a repeated swallowing, because that would indicate to you that he is bleeding, okay? And you would want to notify your physician immediately, because it is an emergency and there's no way you will be able to stop that bleeding. I'll show you or tell you about some of the ways in which we might be able to provide support for that type of bleeding, and only the physician will be able to implement those treatments for posterior bleeding. Okay. The next thing that we see with these patients that they could have is a nasoseptoplasty, and that's basically a submucosis resection. And what this concerns is someone who may have a deviated septum that might continuously have symptoms of a stuffy nose, snoring, recurring sinusitis. Sometimes with major septum deviation, it can obstruct the nasal passages or actually interfere with airflow or sinus drainage. What they actually can do is take out the cartilage and put it back in. And this again is done on an outpatient ambulatory surgical procedure, just like your rhinoplasty, and much of the same care is for this type of surgery as it was for the rhinoplasty. Okay? Okay, the next one, as you see up here, is epistaxis. I'm not going to go into a lot of detail with that because we know what an epistaxis is. It's a fancy name for a nosebleed. Okay? Could be many, many reasons as to why somebody has developed a nosebleed. It's a very common problem because of the vasculature within the nose, many capillaries, and this can occur as a result of any kind of injury or trauma. It could also be a sign that someone is developing hypertension. Sometimes blood dyscrasias, meaning that they have some kind of problem with a very serious situation such as leukemia, or any problem with platelet problems, or even a tumor. Maybe somebody really blows their nose very hard, or even somebody has a really bad habit of nose picking. Think about your patients too that may abuse drugs, such as your chronic cocaine users, and even somebody who's a patient in the hospital that you may have to deep tracheal suction them and go through the nares. You can cause a lot of trauma to that area and cause nose bleeding. Even people that have NG tubes inserted also. And remember, older adults tend to bleed more often from the posterior portion of the nose than your younger patients, okay? Many times in itself, it's not a serious problem. Maybe they are really tired of having frequent or reoccurring nosebleeds, and maybe they want to go see their physician because they're concerned that this is happening a lot more frequently. Maybe they notice that every time they blow their nose or they sneeze that they really bleed. And it can be a very scary thing because, as I said before, it's such a vascular area that it really looks like they're bleeding a lot, and it's a little bit scary for some people. So if this happens in the hospital, obviously to document the amount and the color of the blood, and obviously take your patient's vital signs. If they've had a history of this, it's important to ask the patient about how many times a week or a month they have nosebleeds occur, how long they last, and what may have precipitated the issue from occurring. Your book gives a great chart about the best practices for patient safety and quality care with someone who may have an anterior nosebleed. I think they get really nervous when they see a very bloody area that comes from their nose, so it's important to, first of all, position the patient upright and leaning forward to prevent blood from entering the stomach and possible aspiration, and that's what our concern is, because think about where that blood is going at. And reassure the patient and attempt to keep him or her quiet to help reduce their anxiety and also to prevent from their blood pressure from going up. Usually apply direct lateral pressure to the nose for about 10 minutes, and then you may want to apply ice or cool compresses to the nose and face if possible. Kind of constrict those blood vessels to hopefully minimize or stop the bleeding. Sometimes nasal packing is necessary. You might want to use some type of gauze or even some type of thick padding, which we may call nasal tampons. And you want to prevent rebleeding from dislodging clots, so you would really want to tell the patient not to blow their nose for at least 24 hours, because if you open up those clots, you may start the bleeding all over again. If these aren't effective, then it's probably necessary that the person may have to go to the emergency room. Okay. So what are we going to do for these people that maybe have reoccurring nosebleeds? Obviously, we're going to look at our patient's medications, make sure that's not the cause. Are they on any anticoagulants? Are they on aspirin? Things like that. We may also want to think about making sure that this is not a posterior nasal bleed, because if it is that, we may not be able to stop that, and as I said before, it cannot be easily reached, and the patient can lose a lot of blood quickly. So what we would want to do is, if it is a posterior bleed, obviously get the patient, call the doctor and get the patient to the hospital. And many times, your book shows some pictures of what kind of epistaxis catheters may be inserted to put pressure on those areas to stop the bleeding. They may need posterior packing, and as I said, epistaxis catheters that actually is put into the posterior nasal region. And many times with the packing, the physician will position a large gauze pack in the posterior nasal cavity above the throat, and what is on the end of that is some type of thread that attaches the string through the nose and tapes it to the patient's chest to prevent pack movement. And remember, epistaxis catheters look very short. They're only about 6 inches. And these have like an exterior balloon along the tube length in addition to an anchorage balloon on the end. And this is what kind of puts pressure on that area. And sometimes they can be a little bit uncomfortable. And you have to watch a patient's airway, because sometimes it can obstruct and impair gas exchange if that packing would actually slip. So again, with these tubes, obviously you're watching for any bleeding, but our main concern is looking for any signs of a respiratory distress. Okay, so that's pretty much those types of injuries, the nose, and then looking at and assessing whether or not we have a problem with posterior nasal bleeding. And just to mention that sometimes posterior bleeds do not respond to packing or even these tubes that I just mentioned, so it's necessary to get in there and actually cauterize the blood vessels, actually ligating the vessels, or sometimes performing an embolization of the bleeding artery with interventional radiology. So, and there could be some potential problems from that type of very aggressive treatment. So, very, very closely assessing these patients, because bleeding can be a very, very concern, and there might be some various ways in which we control that with different patients. Okay? And as you can see, this slide shows you some of those type of tubes they would use to insert to help posterior bleeding. And these are additional interventions we'd provide for the patient to humidity, oxygen, bed rest, antibiotics, and pain medications. Again, we have to continue to assess their airway to make sure it is patent. We do that by listening, visual assessment, and again, things such as like pulse ox to see if they are desatting or anything like that. All right. The next thing, just going to talk quickly about nasal polyps. All these are is benign grape-like clusters of mucous membranes and connective tissue. May actually obstruct nasal breathing if they're big enough, and they can actually change the character of nasal discharge and even change speech quality. Usually the treatment of choice is a polypectomy, which means they have to actually remove them. They can do it either under a local or a general anesthesia. Again, watching for any bleeding. They get packed with gauze for 24 hours. They'll come back if they're not completely removed, and this is what they kind of look like. And you can see that they can be fairly big and actually obstruct airflow. Okay. The next thing is cancer of the nose and sinuses, and these are actually tumors of the nose and sinuses that may occur. But remember, this is very, very rare type of cancer, and they can either be benign or actually malignant. It's more common to people that are around exposure to wood dust, dust from textiles, and leather dust, and other types of materials. And if you smoke and are around these types of substances, you're even more prone to acquiring cancer of the nose and sinuses. The good thing is the onset is very slow, and many times when symptoms first occur, it may resemble sinusitis, but obviously with advancement of the tumor, it will spread to the lymph nodes, which will cause and show definitely a local lymph enlargement. And it usually would make sense that it occurs on the same side where the tumor mass is occurring. Symptoms will get more severe without a diagnosis and without, obviously, intervention. They will have continuously persistent nasal obstruction, drainage, and that can be very bloody, and they can also start developing pain. Even after they get treated, which they think is due to sinusitis. Obviously, to detect this tumor, we would see it on an X-ray, a CAT scan, or even an MRI, and definitely a biopsy would be done to definitely verify the diagnosis. The best treatment would be surgical removal of the tumor, and usually that is combined with radiation therapy and some of the intensity modulated radiation therapy. And we're going to talk a little more about that when we get to hematology and oncology. So I'm just kind of touching the surface that these may be some types of treatment. Of course, chemo may be used with some tumors. And remember, depending on how extensive the surgery is, will interfere and change in body image or speech, along with how a person would eat, causing them to have definitely altered nutrition, and especially when the maxilla and the floor of the nose are involved in the surgery. They're going to also have changes in their taste and smell. And again, any type of surgical treatments to this area would make it especially important to monitor for any type of hemorrhage or respiratory compromise. Again, assessing the wound, providing proper nutrition, and sometimes if the surgery is very aggressive, maybe a tracheostomy would be needed, okay? Think about the nursing care to provide to these types of patient, careful mouth and sinus cavity care with many times you might see saline irrigations ordered with that, water picks, Sonacare, or even just using a simple syringe. We want to also watch these patients and monitor their pain level as well as for signs and symptoms of infection, okay? All right, the next thing we're going to talk about is facial trauma. All right, with facial trauma is usually described by a specific bone, maxillary, orbital, mandibular. That's probably one of the most common types of facial trauma that we see is the lower jaw or the mandibular types of trauma. And they also like to differentiate which side of the face is involved. And as you can see here, we call those or name those or label those types of injuries and facial trauma by Lefort 1, Lefort 2, Lefort 3. Again, that primary assessment is the airway, and making sure that there is proper gas exchange happening, okay? We're real concerned about any type of airway obstruction, such as stridor, dyspnea, anxiety, restlessness. That's what you usually see first when these patients start to be desatting and being compromised. They'll become very hypoxic, along with an elevated CO2 level, which we call hypercarbia, okay? And obviously their O2 sats will start decreasing, and then you're going to see definitely color changes. Patients will become cyanotic, and if that PaO2 gets low enough, the patient may lose consciousness. And again, looking and assessing airway, assessing at the site of trauma, because think about it, when we look at the different degrees or the different labels of facial trauma, you see which one your patient has. And remember, the facial area does have a great supply of blood, so anytime we see trauma to that, it could result in extensive bleeding, along with extensive bleeding as well as extensive bruising. And you can see where the Lefort 3 is a combination of 1 and 2 plus an orbital zygoma fracture, often called craniofacial dysfunction, and which really means that the midface has actually no connection to the skull. So you can imagine how serious this type of injury is. Another concern, any type of injury to the face, again, assessing for any type of skull fractures. Look at facial asymmetry, leakage of spinal fluid through either the ears or the nose or even both. Assessing vision, that's very important, looking at eye movement, because orbital and maxillary fractures can actually affect the eye nerves and the muscles. And also check behind the ears in that mastoid area for extensive bruising, known as the battle sign, which is often associated with a skull fracture and brain trauma. So we're going to also be doing neuro checks on these patients, because many times facial trauma can occur with spinal trauma and skull fractures. Again, the priority action is to establish and maintain an airway for adequate gas exchange. Depending on the severity and the extent of the injuries, the patient may need a tracheotomy or a cricothyroidotomy. It just depends. Really, these are some of the first things we do on these types of injuries. Really initiating, an airway, making sure that's in place. Really assessing and diagnosing at what extent the facial trauma is, making sure we're controlling hemorrhage, and some of these patients may lose a lot of blood, so they become hypovolemic and get real shocky. So again, we want to be prepared to give blood, fluids, things like that. Time is really essential. Who has had some kind of head or neck trauma. So early response and treatment by these special teams is really essential for the prognosis of how these patients are going to recover. Many other disciplines may have to be called in as consults, especially plastic surgeons. This is one field that definitely will be, because if these patients need some kind of surgical intervention to repair the damage, you want a specialist, because this is the face. We want to minimize scar tissue as much as possible. Many times your oral surgeons or your maxillofacial surgeons may be involved, because with these fractured jaws, the patient may need to have a fixed occlusion where they actually have to wire the jaw together with the mouth in a closed position. And these patients will have to be in that fixed occlusion for sometimes 6 to 10 weeks. And many times instructing these patients on how to care for that oral cavity is of utmost importance, because with poor oral care, many of these jaw injuries can lead to some serious infections, okay? And so there can also be extensive jaw fractures, which may require open reduction, and all kinds of other aggressive treatments where might be needed depending on the extent of the injury, plates and screws and things like that. This is a good time when these types of injuries occur that oral care can be done very, very successfully with water picks or even Sonocares, okay? And many times when we have these patients in the hospital that have these fixed occlusions done, it's very important that we as nurses keep a pair of wire cutters at the bedside, okay, just in case these patients would have some kind of emesis. We don't want them aspirating. So very, very serious situation can occur when these patients have facial trauma. Many times these patients will be in intensive care in a critical care unit, because they have to be observed very closer for any kind of airway compromise, bleeding, and infection. And this is a picture of the Lefort fractures and how they look 1, 2, and 3, okay? And as I said, these are the various interventions. I talked somewhat specifically about each one. Think about debridement too. Sometimes that's also done to clean away the dead tissues, and then again, to minimize or prevent infection, we would put these patients on antibiotics. I'm not going to get into this again. We talked somewhat about this when we talked about CPAP and BiPAP, but obstructive sleep apnea obviously can affect airway considerably. Breathing disruption during sleep that lasts at least 10 seconds and occurs a minimum of 5 times in an hour would be diagnosed as obstructive sleep apnea. And because these patients are not really getting into a deep sleep, they're very tired the next day, and that's represented by their behavior. Might also be very sleepy, unable to concentrate, and become very irritable, because obviously they're not getting a very good sleep at night. Certain people are more at risk for developing sleep apnea: people that are obese, people that have a short neck, people that have a large uvula, and even people that smoke. Also, if some people have, were born with large tonsils, those can all be factors that would possibly make someone more at risk to developing sleep apnea, okay? But sometimes it can also be neuro in origin, but many times it can be due to a soft palate or a tongue. But unfortunately, it could be due to airway obstruction. But what we do know is apnea is a word that means that a person has quit breathing, and that's what happens through the night. And because of that hypoxic drive that signals the brain to breathe again, patient will wake up suddenly gasping for air, because what's happening is their PaO2 is dropping and their CO2 is climbing along with their pH dropping. So many times These patients non-surgically can be managed through just weight loss, change of sleep position, and as I talked about the other day, positive pressure ventilation or a CPAP machine at the bedside. Many times the patient doesn't even realize it for a while. It might be recognized more by family members. And this next slide is obviously a CPAP machine. And when these are finally provided to the patient to help with their sleep apnea, the companies that make these machines are very much providing instructions about how to clean these machines, because many times these patients can get infections if these tubings and these masks are not cleaned properly. They can actually inhale bacteria, causing them to develop respiratory infections. Along with some sleep studies, these people that are suspected of having sleep apnea may have a PSG or a polysomnography, and they might also do an EEG, ECG, and EMG just to kind of determine and make that verification that the person does have sleep apnea. And many times during sleep we know that the muscles start to relax and the tongue and neck structures are displaced. And as a result, the upper airway is obstructed, but chest movement is unimpaired. So, that's kind of what happens for these patients. Like I said before, many times it's the patient themselves that are very unaware that they have it. And, maybe they start putting two and two together when somebody, their spouse or person that they sleep with, maybe they start to snore heavily, and it's very much verified by other family members. The patients can have a beginning assessment, and they do the Epworth Sleepiness Scale, and the patient is asked to score his or her likelihood of falling asleep during 8 common activities or scenarios, and each is self-scored from 0 to 3. And a person who scores 18 or above are considered a risk for severe sleep apnea. And I've talked about, who would be at risk for that. Remember, with our nasal CPAP, it delivers a set positive airway pressure continuously during each cycle of inhalation and exhalation. And so the important thing is that it's a proper fit of the mask over the mouth and nose is really the key to a successful treatment. There's also drugs that have been approved to manage the daytime sleepiness associated with sleep apnea, and that drug is called modafinil, and it's helpful for patients who have narcolepsy, which is uncontrolled daytime sleep. They just kind of fall asleep at a whim from sleep apnea by promoting daytime wakefulness. And it just is treated for that, and it really is not a drug that treats the cause of why sleep apnea is occurring. There's also surgical interventions, as I said, along with non-surgical, and these are adenoidectomies, uvulectomies, and that other long word on the screen, palato-pharyngeoplasties may also be done just to kind of reconstruct those structures so the patient doesn't have apnea anymore. Okay, now we're going to look at the larynx and look at some of the disorders we might find with patients who might have disorders of the larynx. The first one is vocal cord paralysis, and that can result from injury, trauma, or any kind of diseases that will affect the larynx. It could be the larynx nerves or the vagus nerves. Sometimes we see this happen when people are intubated and those endotubes are in for a long period of time. And it can be either temporary and it's rarely permanent paralysis. It can also occur with neural problems, damage to the vagus nerve, maybe a chest injury, or maybe a brainstem injury. And laryngeal nerves may be damaged from trauma or disorders that involve the chest, the esophagus, or the thyroid. Usually one is affected, but you can see paralysis of both vocal cords occur. That, as I said, may result from injury brainstem stroke, or even a total thyroidectomy. Okay. And it's most common to have only one of the vocal cords involved. The airway remains patent, but the voice is affected. And so manifestations of open bilateral vocal cord paralysis include the voice being very hoarse, breathy, it's a weak voice, and sometimes aspiration of food. Bilateral closed vocal cord paralysis can cause airway obstruction and is an emergency if the manifestations are severe and the patient cannot compensate. One first sign that the patient is having respiratory distress is stridor. Stridor is very serious, and this is where you at this time should initiate and immediately notify the rapid response team if the dyspnea with stridor occurs. And this is where maybe we might need to re-intubate if that's the cause of it, or intubate for the first time, or maybe do a tracheotomy. We want to make sure that that airway is present, and so we obviously place the patient in a position of high fowlers to help them with their breathing and to keep that airway in proper alignment. There's various surgical procedures that can help improve the voice. One simple procedure for open vocal cord paralysis, they can actually inject a polytef or a Teflon into the affected cord so it enlarges toward the unaffected cord. And this techniques will, since you're enlarging it, will actually provide closure during speaking and eating. So I thought that was kind of interesting that can happen. And remember, the patient with open cord paralysis is at risk for aspiration because now the airway is open during swallowing. So that's where, as they eat, that food can actually get down into the respiratory tract where oxygenation is. So ask them to teach him or her to hold their breath during swallowing, to allow the larynx to rise, close, and push back food into the esophagus and not go down into their trachea. And they can also learn to tuck their chin down and tilt their forehead forward during swallowing. Okay, so we want to worry that they don't develop an aspiration pneumonia with this. So that's one type of disorder of the larynx. The next one is vocal cord nodules and polyps. Your book doesn't talk about this, but I'll just bring it up briefly because it was in the earlier edition, and some of you may have that, edition 7. The nodules may be enlarged, and you have enlarged vocal cords touched during speech. So what they are basically is chronic edematous masses. And we see this a lot with people who smoke or have allergies or who live in dry climates. They can also have vocal cysts may occur. And what we just encourage with that is no tobacco, they rest their voice, no speaking, not even any whispering, and no heavy lifting. Many times, if they have to have surgery to have them removed, they have 14 days of voice rest post-op, and usually that will take care of the problem. The next issue is laryngeal trauma. Okay, this is when some kind of crushing or direct blow to the larynx occurs, maybe again with prolonged endotube intubation. And when someone does have laryngeal trauma, some of the signs and symptoms that we see are difficulty breathing, which is a serious situation, aphonia, hoarseness, subacute emphysema, bleeding from the airway. And what we can do is actually, the physician may to actually assess exactly what the extent of the injury is. This is where, remember last week we talked about laryngoscopies. This is where they would do that. So they would actually scope the area, the larynx, to do a direct visual exam to assess the injury, and then make that diagnosis. Again, watching airways, providing O2, humidity, look for signs and symptoms of any respiratory distress. Sometimes surgical intervention is necessary, and again, maybe an artificial airway may be needed. remember too, our big concern is obviously respiratory difficulty. So if your patient's ever having respiratory difficulty, it's very important that you stay with them and that you call the rapid response team to prepare for maybe some type of intubation or even a tracheotomy, because we don't want to get them to the point where they actually can't breathe anymore, because then what we would see is someone developing obviously a respiratory arrest, and you know how that continues to snowball, causing the patient's cardiac status to deteriorate and renal system and everything like that, because then the body goes into some kind of anaerobic metabolism, which is a very serious thing, trying to metabolize cells and energy without oxygen, and you can see the seriousness of that. Another thing too is airway obstruction, upper airway obstruction. This is a life-threatening emergency in which an interruption to the airflow through the nose, the mouth, the pharynx, or the larynx occurred. Again, early recognition is essential to prevent further complications, including just what I talked about, respiratory distress. There is a lot of things, and your book gives many reasons why upper airway obstruction can occur. Somebody that has tongue edema, maybe they've had allergic response to something. Tongue occlusion, where they lose their gag reflex and the tongue kind of falls back and they've lost muscle tone. Laryngeal edema, peritonsillar and pharyngeal abscesses, head and neck injury, things we've already talked about. One thing is important too is, you might not think about it, but I talked last week about it, thick secretions. Stroke and cerebral edema, where you have the neural aspect of breathing kind of involved. Smoke inhalation, edema, facial trauma or laryngeal trauma, foreign body aspiration, burns, because burns we know cause a lot of edema, and anaphylaxis. One preventable cause of airway obstruction leading to asphyxiation is in speciated, thickly crusted oral and nasopharyngeal secretions. This is really important that I want to bring this up. This is somebody who maybe isn't taking things orally, and nurses from shift to shift are not really looking in that oral cavity. And what this means is, on the roof of the mouth, many times thick secretions accumulates, and without proper mouth care, this continues to build layer after layer of these thick crusted secretions. And with poor oral hygiene, they become so thick and hard that they can actually start to block the airway, and this can of course lead to death. So again, making sure when your patients are not drinking or eating that we are definitely doing good mouth care on these patients to prevent this problem of inspissated oral and nasopharyngeal secretions. Okay, very, very important. And I've seen that where you actually peel it off the roof of the mouth. It is very gross, and some of those become so very foul smelling, but you got to get them out, because it can cause total occlusion in that airway area. Okay. And the next thing we're going to talk about is neck trauma. This is any neck injury that can be caused by a weapon or trauma, and the person that may have neck trauma will also or can also have other types of injury, including cardiovascular, respiratory, intestinal, and neurological damage. Obviously, initiating a good assessment to determine exactly what the extent of the injuries are. Think about the neck and what important structures are there. The carotid artery, the esophagus, even the cervical spine can be involved. So if we're not really sure if the patient has any cervical spine injuries, you might want to prevent excessive neck movement. Okay. Again, with neck trauma, make sure that the airway is patent, and after we know that it is, assess for any bleeding or impending shock, because think about the carotid. If that starts bleeding, patients can deteriorate very, very quickly. Okay. Again, also assessing them neurologically, sensory as well as motor. And remember, if they bleed from the carotid, they could really have some kind of serious stroke or even death, because this is their source of blood flow to the brain. Then esophagus, look for any chest pain and tenderness, oral bleeding, and also crepitus, which is that pushing down on the tissues, that crackling sound when palpating the skin. They may have to do some kind of gastrographin swallow to root out any type of esophageal perforations or injury. And again, cervical spine injuries, okay, is very important to make sure the patient will not have any long-lasting spinal problems. So be very careful. And if we don't want to make these problems worse, so if they need some type of CPR, be very careful about that maneuver of, the head tilt for patients with a possible cervical spine injury. Okay? All right, the next one we're going to talk about is head and neck cancer. And again, think about the head and the neck. These types of tumors can definitely disrupt and impair gas exchange, along with how a person eats, even their facial appearance, their self-image, their speech, and of course communication. These can be absolutely devastating type of cancers even when cured, because a lot of them might need surgical interventions. And usually these head and neck cancers are usually squamous cell in nature, and these are very slow-growing tumors. But the key to curing them is to treat them early. And the prognosis for those who have more advanced diseases really depends on the extent and where actually the location of the tumors are. If they're not treated, that usually a patient will expire within 2 years of diagnosis. It really begins as a loss of cellular regulation when the mucosa is chronically irritated and becomes tougher and thicker. And that's how the nature of the tissue starts changing and becomes, more cancerous and malignant. Some of these lesions may be seen as white patchy lesions, leukoplakia, or red velvety patches called erythroplakia. The head and the neck cancer first spreads into nearby structures such as the lymph nodes. Makes sense, the muscle and the bone, and later it will go to systemically to the liver or the lungs. They actually stage cancers, carcinoma in situ and well-differentiated areas, and they will either progress to more moderately differentiated and finally poorly differentiated. And as I said before, most of these head and neck cancers arise from the mucous membranes and skin, but they can also start from the salivary gland, the thyroid, or other structures. So people that smoke and drink a lot of alcohol are very much at risk for developing these types of cancers, head and neck, especially if they do both. Also, people that abuse their voice, chronic laryngitis, exposure to a lot of chemicals, and poor hygiene. Severe gastroesophageal reflux disease is also thought to be a major risk factor for developing head and neck cancers, and also oral infections with the human papillomavirus. There's about 60,000 new cases of oral, pharyngeal, and laryngeal cancers diagnosed each year, and account for more than 13,000 deaths per year. Okay, the important thing is to look at the history of these patients. And in your book, in the 8th edition on page 538, there's a lot of warning signs of head and neck cancer, and which could allude people to the possibility that they are developing some type of cancer. And these are all the different types of interventions: radiation, chemo, cordectomy, laryngectomy. And these will all be very dependent on where the cancer is and how far and progressive the cancer is, and if we have any type of metastasis occurring. I'm not going to get into the side effects in regards to radiation and chemo, because we're going to talk about that in much more detail when we get to oncology with hematology. So for all study purposes, it's not necessary to learn these in depth right now until we get to that particular system, okay? Because there's a lot of things that are important to know as to, our patients who do develop cancer. We're just kind of talking about the potential of developing cancer in these areas, because this is the upper airway structures that we're talking about. I do want to talk about cancer of the larynx, and when we talk about laryngectomies, so we'll talk about either temporary or permanent laryngectomies, and kind of the teaching and what it entails, and some of the surgical procedures that we want to look at, and what happens to that person after they do develop cancer and have to have either a partial or total laryngectomy. It totally changes their life. When we talk about laryngectomies, a partial laryngectomy, that is where the trach will be temporary. In a total laryngectomy, that is where the upper airway is actually separated from the throat and esophagus, and the trachea is brought out from the skin in the neck and sutured in place. So this creates a stoma that is permanent. Many times these people that acquire cancer of the larynx, it really starts metastasizing to the lymph nodes, and these people not only need a laryngectomy, but we also do what we call a radical neck with a neck dissection, because it has advanced into the lymph nodes, and this surgery is quite extensive, where lymph nodes will be removed, part of the sternocleidomastoid muscle, the jugular vein, the 11th cranial nerve, the accessory cranial nerve, and some of the that actually innervates the trapezius and the sternocleidomastoid. This is a long surgery, because obviously look at all the structures that will be surgically removed or partially removed, and reconstruction will have to be done with tissue flaps, with the reconstructive process and the reconstructive surgery. These patients will have shoulder drop. They'll need PT after surgery, after they recover, to be sure that there are no complications. It's a long surgery. It can go anywhere from 8 to 10 hours. And again, our concerns after this type of surgery, they're going to be in a MICU or a SICU, and we watch for airway obstruction, hemorrhage, wounds, skin breakdown, and we're going to watch to make sure these patients don't have tumor recurrence, meaning that tumor is going to grow back. They're going to have a laryngectomy tube, which is a lot shorter, and the diameter is wider than actually a trach tube that we talked about last week with tracheostomies. Many times the tissue flaps will be used in the reconstruction process, and again, our big concern is hemorrhage, wound breakdown, pain management, nutrition, speech and language. These people will have to carry an emergency card in their wallet. It's going to be quite obvious that these people have a permanent laryngectomy. It's not a real common type of cancer, but we can really, it is curable if it's detected early. Most of these cancers are squamous cell, and it's one of the most common types of malignancies. And probably the first sign of laryngeal cancer is hoarseness or a change in voice. And then if nothing is really detected at that point, it continues to worsen by painful swallowing, foul breath, earaches, and palpable lump. To diagnose it, they'll either do a direct or indirect laryngoscopy, and of course imaging along with a biopsy. Of course, the staging process will occur: tumor size and location, number of involved lymph nodes, and the presence or absence of metastasize, and that will go anywhere from 0 to stage 4. Radiation and chemotherapy may be needed depending on the extent of the tumor. We see about 10,000 new cases a year. Men are more prone than women are, usually in the age group of 50 to 70, and 50% are more often African American males. A lot of the carcinogens, alcohol, tobacco, and exposure to asbestos puts a person more vulnerable to acquiring cancer of the larynx. They categorize it in 3 categories. If it's involved with the supraglottic, those are the false vocal cords. About a third of people get that type of cancer. 2/3 get the glottic, which are your true vocal cords, and then there's the subglottic. 25 to 50% are present with involved lymph nodes, and prognosis with small laryngeal cancers without evidence of spread to lymph nodes is really good, 75 to 9%, and reoccurrences are 2 to 3 years after diagnosis. We talked about some of the early signs and symptoms, and then the late signs and symptoms would be dysphagia, dyspnea, and obviously medical management depends on staging. We'll first start with radiation and kind of shrink that tumor. Remember, when we do a laryngectomy, the patient will have absolutely no voice, and they'll have the need to breathe through a stoma in the lower neck. Sometimes with a partial laryngectomy, they may include voice-sparing results for the patient who has an early laryngeal carcinoma. So that's one that we definitely detect early. Okay. The goal is obviously to remove the malignancy and maintain as much airway as we possibly can, and hopefully achieve optimal cosmetic appearances. Sometimes they can actually do lasers on the tumor if it's found early, and then the patient may need only a temporary tracheostomy. And that temporary tracheostomy might be for only about 5 to 7 days. Depending on whether or not the epiglottis is removed, you want to monitor for aspiration. Sometimes tube feeding for nutrition and swallowing techniques. With a total laryngectomy, remember, it's a cancer that's obviously beyond the vocal cords. The entire larynx is removed along with the epiglottis, and the thyroid cartilage, several tracheal rings, and the hyoid bone. These are kind of what I'm showing you on the screen as far as post-op care. Remember, the trach and the esophagus will be totally separated. The voice is totally lost, and the trach is definitely permanent. And as I said, depending on how extent the tumor is and the cancer, they'll have a radical or modified neck dissection. And I told you about all the parts and pieces that will definitely be removed with a radical neck. And then they use skin grafts or flaps to use to actually close the wound. The patient will have a hemovac drain in place to prevent hematomas and extensive edema. And because of all that muscle that's been removed, patients will also have difficulty turning and lifting head. Now, if there's any good thing about it, because this trach and the esophagus are totally separated, there's no chance of any type of aspiration when the patient can resume eating. Again, our concern is change in body image, speech therapy, because communication will now be a problem. And there are esophageal speeches, artificial larynxes, all that can be definitely implemented when we know that the patient has developed no complications that I talked about earlier, wound flap infections, hemorrhage, wound breakdown, pain management. So we have to figure out a way in which we can, provide nourishment. Sometimes patients have an NG, gastrostomy, jejunostomy tube, where we can implement feedings temporarily while the patient is still trying to heal and recover. So that's what our immediate concern is, to hopefully get them through that first few days of post-op care, so we don't see any complications occur. And then explaining about coughing and deep breathing and clearing secretions. If a patient knows he is going to have this type of surgery, it's very important that we as nurses provide good pre-op teaching to these patients. And they're going to have to learn about, stoma care, inspect the stoma with a flashlight, how to clean the suture line with sterile saline or prescribed solution to prevent, those secretions from forming crust and obstructing the airway. We're going to have to look at that suture line care every 1 to 2 hours for the first few days after surgery, and then every 4 hours. And it's important to make sure that the mucosa of the stoma and the trachea should be bright and shiny and without crust, similar to the appearance of the oral mucosa. We look at that wound flap and reconstructive tissue care. First 24 hours, obviously, are the most critical. And evaluate all those grafts and flaps hourly for the first 72 hours to make sure that they all took. And, of course, hemorrhage is of extreme importance. Wound breakdown, and you want to be careful too of that carotid artery rupturing. If it does, call the rapid response team and be careful not to touch the area because additional pressure could cause an immediate rupture. Just place constant pressure over the site and secure the airway, okay? Because we know with a carotid artery rupture, it has a very high risk for stroke and death. Pain management will also be of utmost importance for these patients. Morphine, and maybe giving a PCA pump for the first 1 to 2 days after surgery. Nutrition. The patient may, as I mentioned before, a feeding tube may be in place for 7 to 10 days after surgery. And of course, speech and language rehabilitation. I'm not going to explain those. You guys can read about, what to expect with that type of post-op care. And then esophageal speech. Looking in the green boxes about prevention of aspiration during swallowing, and patients after a laryngectomy, and what do we do for these patients when they actually go home. So that pretty much concludes that chapter, chapter 29. And if you have any questions, feel free to ask me next week or Monday, tomorrow when we meet. And then if you still have questions before the test, I'd be more than happy to assist with that. I just want to talk somewhat on Chapter 31 in IGGI 8th edition on care of the patients with infectious respiratory diseases and respiratory problems. Some of these are fairly minor. The reason we bring these up and talk about them is because there is a chance of, because it's an infection, we could see potential problems where the infection can spread and definitely cause airway problems and definitely impair gas exchange. The first one is rhinitis, and that's just a fancy name for, hay fever or the cold. It's just an inflammation of the nasal mucosa or nasal cavity. It can be either chronic or acute, and acute is called the common cold, and chronic is more symptoms that kind of resemble hay fever or allergies. These are some of the drugs over the counter that we may see used, some of the antihistamines and decongestants, antipyretics, and antibiotics. Remember, it's an infection. Many of these are viral, so we may give antibiotics just so we don't see someone develop a superimposed infection. Sometimes complementary and alternative therapies might be initiated. And just helping the patient, encourage the patient to be comfortable and to prevent the spread of infection, good hand washing, things like that. Many of them are pretty much caused by viruses, but can also see some superimposed bacterial infections occurring. The things we get concerned about are the development of cellulitis, abscesses, and meningitis, which are very extreme. And sometimes that drainage can be very annoying, can come from both one or both nares. And you want to be very careful in some of the over-the-counter drugs, especially for the elderly, okay? The next one is sinusitis, and basically is, your patient having inflammation of the mucous membranes of the sinuses. Very common. Sometimes you can see it occurring after someone has an upper respiratory infection. And again, can cause, can be anything that impairs drainage, nasal polyps, deviated septum, rhinitis, or even a tooth abscess. Maybe acute or chronic. Chronic conditions usually occur because the acute manifestations of the infection was not treated adequately. You want to treat it because many times these can obstruct drainage, and over time those mucous membranes can become very thickened, and complications of these can spread to other areas, periorbital abscesses. You can diagnose it by CT scan, or if you suspect it's from a malignancy, by an MRI. Obviously, it's a bacterial infection, and we'll treat it with broad-spectrum antibiotics such as amoxicillin, analgesics for pain and fever, decongestant, steam, and humidification, and sometimes hot and wet packs over the sinus area help a lot. Sometimes nasal saline irrigations, increased fluid intake unless they're on some type of fluid restrictions. And a lot of times we'll do irrigations, antral irrigations, to remove some of that fluid or pus, or a Caldwell-Luke procedure where the actual infected mucosa is removed, and a nasal anthral window procedure which improves drainage from the nares. Sometimes endoscope sinus surgery is needed to help that. Pharyngitis or sore throat is a common inflammation of the pharyngeal mucous membranes that often occurs many times with a cold, such as rhinitis or sinusitis. It accounts for up to 40 million office visits each year in the United States. Remember, acute pharyngitis can either be caused by a bacteria, a virus, or other organisms, sometimes trauma, irritants, or dehydration, or even things that we drink or eat or smoke can cause the throat to be sore. Our big concern is the bacteria called Streptococcus, which is a very serious and can be a very deadly bacteria, and many times along Sorry I lost my feed on the PowerPoint, but I've got it back now. So as I was saying about pharyngitis, when a patient presents with a sore throat, it's important that they have a strep quick test done. They can swab the throat and determine if it's strep. It's a bacteria, so a patient needs to be on antibiotics and to take them for the prescribed amount of time that they have been issued, to make sure that we have completely eradicated the bacteria, because we know the serious complications that can occur with group A streptococcal infections, rheumatic fever, acute glomerulonephritis, peritonsillar abscesses, otitis media, sinusitis, mastoiditis, bronchitis, pneumonia, and scarlet fever, just to name a few. So it's really important that you're checked for that and to follow the prescription completely. Along with strep, these patients also are very, very sick. Odonophagia, dysphagia, fever, and hyperemia. They're going to have a lot of pain on swallowing, difficulty swallowing, and they may also have fever. Okay. Epiglottitis is also a complication that you may see with pharyngitis, and again, we're preventing these serious complications along with possible airway obstruction. And as you can see, that many times you might see how serious this infection can get and how the airway can be extremely compromised. Along with pharyngitis is tonsillitis, which is an inflammation infection of the tonsils and lymphatic tissues. It's a contagious airborne infection, usually bacteria. What we like to treat this with is obviously antibiotics and sometimes surgical intervention. Patients, especially young people, over recurrent tonsillitis problems may have to have their tonsils or adenoids removed at some time. I'm not sure the incidence of how much we're doing that nowadays. It used to be very common when I was a child, but I'm not sure that we're doing that now. But again, antibiotics, antipyretics, and watching for the potential of peritonsillar abscesses from occurring. But yes, frequent infections may need someone to see a ears, nose, and throat man to do a tonsillectomy on that person. Now this is a peritonsillar abscess, which is a complication of acute tonsillitis. What happens is there's a lot of pus behind the tonsils causing one-sided swelling with deviation of the uvula. And what these people start to manifest is the problem with trismus, which is that tonic contraction of the muscles of the mastication for chewing. You're unable to open the mouth completely, caused by muscle, joint, or nerve problems. And this is a very serious situation. And as you can see, there's a good picture here of peritonsillar abscesses, and you can see them right here in the back of the throat, and you can see how swollen this area is and how hyperuremic it is as far as redness and these pussy abscesses. And it's really very much constricted airflow. And my daughter had this, and what they actually did in the office was kind of excise these in the office, and a lot of pus and bleeding occurred, but I put her on a very potent antibiotic, and she was fine after that. But you can see she was really, really sick with that. Laryngitis, it can be related to any kind of disease process, throat, lung cancer, tobacco, and alcohol use. Obviously, it's an inflammation of the mucous membranes lining the larynx, possibly including edema of the vocal cords. And I just talked about all those upper airway problems, especially ones that do involve the larynx. These are signs and symptoms that you may see: acute hoarseness, dry cough, difficulty swallowing, and temporary voice loss called aphonia. One of the most important treatments is voice rest, steam inhalation, increased fluid intake, throat lozenges, and therapy, relief, and prevention. So that's really important. The next one is influenza, and this is very important that we bring this up at this point because we know, unfortunately, what has happened in our communities with the flu epidemic. It has become a real big problem, and it's not to be taken lightly. It's a very highly contagious acute viral respiratory infection, and some of us have had it in the past, but the strains this season are much more intense, and we've seen a lot of deaths occur because of influenza, and even with people that are in fairly good health, and even in people that have also had the flu vaccine. So it's nothing to be taken lightly. The goal is to prevent yourself from getting it, good hand washing technique, staying away from people who are sick, because like I said, it is highly, highly contagious, and you feel really terrible from it. And I've seen too on the news that some of the treatments such as Tamiflu, which we give a lot of times when symptoms occur, is shown to cause hallucinatory effects in children and even some adults. Yes, we still recommend the flu vaccine, but it doesn't guarantee that you will not get it. And these antiviral agents also may be effective, such as Tamiflu, which I just said. So just wanted to really stress the importance of trying to keep yourself having a lower and less chance of getting or acquiring the flu. That's why I'm saying if you think you do have it, stay home. Don't infect anybody else, okay? Other than that, just taking good care of yourself, getting some sleep, and decreasing stress, eating healthy, and trying to stay away from crowds in which I'm sure some people out there do have some of the symptoms of the flu. Okay. All right. The next one is really an important one, and I may talk about this again in class because this kind of goes with the other important disease processes that you will see with the patients that are on the med-surg floors, or sometimes even the ones in step-down or in critical care areas, is pneumonia. Okay. We talk about pneumonia being either acquired, hospital-acquired pneumonia, more likely to be resistant to some antibiotics that are community-acquired. And what's important when we look at the term pneumonia, we want to think about where the disease process, where the pathology is occurring, what part of the structures of the respiratory system does pneumonia occur in. And it is an excessive amount of fluid in the lungs resulting from an inflammatory process. And it's an inflammation that occurs in the interstitial spaces, the alveoli, and often in the bronchioles. And what happens with this type of disease is a particular organism gets into the lungs, and the body is unable to use its defense mechanisms to rid the body of that particular foreign body into the lungs. So that organism gets down into that alveolar space, and it has to survive that inflammatory process. And what happens is our body tends to fight off this bacteria organism, and so white blood cells will migrate to the area of infection, causing capillary leak, edema, and exudate. So fluid collects in and around the alveoli, causing your alveoli walls to thicken. So unfortunately, this is reducing gas exchange and leads to hypoxia. And this capillary leak spreads to other parts of the body, and it can even cause complications such as sepsis, because the bacteria can spread to the bloodstream and sometimes in the pleural cavity, causing empyema. And along with that pathology that I just described, it stiffens the lungs, reducing compliance and reducing vital capacity. We're going to talk about obstructive pulmonary disease such as emphysema and asthma, but pneumonia is a restrictive type of disease because obviously it restricts lung compliance, thus causing atelectasis, thus causing a decrease in a patient's PaO2, okay? That stiffening of the lung comes from the fibrin and the edema that's occurring, okay? And remember, pneumonia may occur as lobar pneumonia with consolidation, or in a segment or an entire lobe of the lung, as in a bronchial pneumonia with diffusely scattered patches around the bronchi. And how does this occur? Usually it develops when the immune system cannot overcome that invading organism, when it can't fight it off. We get them from the environment, invasive devices, equipment, supply, staff, or other people who invade the body. And risk factors for pneumonia, definitely the elderly. They don't receive their pneumococcal vaccination more than 5 years ago. They didn't get their flu shot. They might have a chronic health problem, or has been recently exposed to respiratory viral influenza infections, and one who uses tobacco or alcohol. That is people in the community who acquire pneumonia, and your healthcare providers are the older adult. Also has a chronic lung disease, such as your patients with emphysema, and you'll see many times those patients will get pneumonia, and that's probably one of the main reasons why they come to the ER, because they really have a lot of respiratory distress. They're really in bad shape, and they come to obviously be admitted and to get some very aggressive treatment. People that have an altered level of consciousness, that recently aspirated something, or are patients that have trachs, endotubes, or even an NG tube, are also very prone to acquiring pneumonia, along with people that have poor nutrition and that are on mechanical ventilators. So those are some of the people when we look at the difference between community versus hospital acquired, okay? In the United States, about 2 to 5 million cases of pneumonia occur each year, and it can be a major cause of death. This is another one of those diseases that we really can't take lightly, that it is still causing people to die, especially the older adults, nursing home residents, and hospitalized patients, and those that I said are like in a critical care unit that are on some kind of assisted mechanically ventilated device. So what do we do What do we do with these patients? Obviously, preventing pneumonia would be the best ideal situation. Obviously, it's more prone to people that smoke, but what our goal is to get these people on antibiotics and oxygen, maybe some type of antipyretics, because these patients can have chills and fever, nasal congestion, sore throat, orthopnea, crackles, sputum, and our goal is to get them better and to assess for complications and to prevent those complications from happening. Many times they'll have chest x-rays, blood cultures. We'll check a CNS of the sputum to determine the exact organism. We're going to watch for things like atelectasis and pleural effusion, make sure they have a patent airway, help them with their secretions, humidity, encouraging rest, proper nutrition, and fluid intake, okay? And we really need to watch their pulse ox and look for any type of respiratory compromise with hypoxemia, listening to their lungs, assessing for any wheezes, watching for hemoptysis, determining if we have adventitious or abnormal breath sounds, watching their color, such as cyanosis, which could alert us to severe respiratory distress. So that's kind of what we want to think about pneumonia. We might be doing ABGs on them, chemistry such as electrolytes, BUN. Remember, with fever, these patients can dehydrate very easily, so we may see an elevated BUN, which denotes that, not necessarily any renal impairment. Remember, these patients may have impaired gas exchange as well as ineffective airway clearance, and they are at a potential for sepsis. Okay, so just wanted to go over that, and we'll probably do a case study involving pneumonia, but I just wanted to stress the severity of pneumonia and that we are seeing some of our patients still dying from pneumonia, especially the elder and some of the ones who have chronic diseases and demonstrate immunocompromise. Okay, and these are things that we want to look at. And I want to talk about tactile phrenitis and why and whether or not we would see it increase or decrease in a patient that has pneumonia, because I want you to understand that term and what that means and what that tells you as the nurse when you make your assessments. These are, again, the labs that we may see on these patients: creatinine, assessing kidney function, imaging, chest x-ray, pulse ox, and they may have frequent chest x-rays done to assess whether or not our antibiotics and our interventions are working for our patient, because that chest x-ray should hopefully be clearing. And remember, these people will go home not feeling all tip-top shape. It's going to take weeks before they feel good again, especially the elderly. They're still going to be weak and tired and still have to continue maybe on some medication. Okay, pulmonary tuberculosis. What is tuberculosis? It's on the rise across all countries. In fact, it's one of the most common bacterial infections in the world. It's very contagious, and it's spread by droplets, which become airborne when the infected person coughs, sneezes, or laughs, and then that droplet is inhaled by another person. But remember that not all persons infected with TB develop an active case. The TB bacillus will lodge within lung tissue and cause the tissue to become necrotic. In most healthy people, the body responds to the TB bacillus and actually controls the infection. It's only about 5 to 15% of those exposed to TB will develop an active case. Those who do usually have weakened defenses against it, such as those with HIV and also the elderly. A person will test positive after an exposure to TB, but does not necessarily have the disease. And that's that Mantooth test that you get as a requirement for nursing school to practice in your clinical facilities. And we look at the skin induration to see if there's any induration noted. We read it 48 to 72 hours after you receive the Mantooth test. And just because you may see induration does not necessarily mean that you have TB. Those persons who test positive need to have a chest x-ray to determine whether they have the disease. Those who do contract the disease usually have a repeated close contact with an infected person who is showing signs of the disease. A disease can also be made on a sputum culture, a sputum specimen for AFBs, as well as a chest x-ray. All right, so as I said before, it is a very slow-growing, acid-fast rod transmitted via the airborne route. So that's important to know. What's the incidence? You know, you can look all this up on the CDC and see how many cases of TB have actually been identified in some of your communities. Worldwide, 8.7 million people were diagnosed, and an additional 1.4 million people died from TB in 2012, which I thought was really quite interesting. Early detection of TB depends on subjective findings rather than observable manifestations. It has a very slow onset, and patients are not aware of the problems until the disease is advanced. And TB should be considered for any patient with a persistent cough or any other manifestations compatible with TB, such as weight loss, anorexia, night sweats, hemoptysis, shortness of breath, fever, or chills. Okay? So, as I said, for diagnostic purposes, and you can read about what kind of manifestations your patients may experience. And these are some of the most frequent ones, as I'm putting up here on this on the PowerPoint slide: progressive fatigue, lethargy, nausea, anorexia, weight loss, irregular menses, low-grade fever, and night sweats. Those are some of the most common types of manifestations that we see our patients exhibit, and cough and mucopurulent sputum, even blood streaks. And a chest examination does not provide conclusive evidence of TB, a new rapid test for tuberculosis has been developed and approved by the World Health Organization, and this test is the fully automated nucleic acid amplification test for tuberculosis, and results are available in less than 2 hours. So that's quite interesting that we've come to that type of diagnosis. And of course, blood analysis. There's also an enzyme-linked immunosorbent assay using the quantiferin TB Gold. Is a relatively rapid test for the presence of M. tuberculosis. Results are ready in 24 hours and are still used in acute care settings to determine whether a symptomatic patient has TB. And that's what you want to know right away, because we don't want to infect other people, because we know how highly contagious it is, and these patients will definitely be put on some type of isolation. Sputum cultures also can confirm the diagnosis, where enhanced TB cultures and automated microbacterial cultures require 1 to 4 weeks to determine a positive or negative result. And cultures are usually negative after 3 months of effective treatment. That's how we can kind of determine if the patients are not contagious anymore. And you know about the tuberculin test, the man-tooth, because an area of induration, not just redness, measuring 10 millimeters or greater, in a diameter 48 to 72 hours after injection, indicates a possible exposure. But like I said, usually a reaction of 5 millimeters or greater with someone with HIV would be is considered positive. Okay. Once a person's skin test is positive for TB, a chest X-ray is used to detect active TB or old healed lesions. So in your book on page 31 are the first line treatments for tuberculosis. Your isoniazid or INH, your rifampin, RIF, and your pyrazinamide, PZA, and your ethambutol, EMB, are all about how we administer treatment and how these patients are treated pharmacologically for when they're actually diagnosed with tuberculosis. Okay, and I want you to read through those, because there's some very, very important teaching that needs to be done when some of these patients are on certain drugs. And just an example would be with INH. This drug can cause liver damage. So if someone has a history of drinking a lot of alcohol, it can potentiate the effects. And so these manifestations may indicate liver toxicity or failure. So that's important to know. And some of your patients will be on sometimes 1, 2, and 3 of these medications for quite a long time, sometimes up to 6 months, to kind of eradicate the tuberculosis bacteria. Some of these can affect your patients if they have gout. Some of them can make someone more at risk for sunburn. So I want you to go over those and look at the nursing interventions, and especially of why we teach them what we do. And the rationales are also provided on page 597. I'm not going to read those to you. You guys can go over those yourself. All right. And this is, again, how we assess someone with TB, kind of looking at their health history, Have they been traveling somewhere? This is how we diagnose it. And then all these combination drug therapies with strict adherence, and that's another part of the teaching that we definitely teach our patients about that. Okay, so I wanted to make sure I and it really made that perfectly clear about home care management, may be managed outside the hospital. Health teachings teach about drugs, must follow regimen precisely, and then that follow-up care for people that need to stop drinking as well as to stop smoking. And I just wanted to say that if a person is going to be treated as an outpatient, it's not necessary that airborne precautions are needed in the family setting because the family have already been exposed to the patient and their disease, but it's necessary that all members of the household or the family need to undergo TB testing. When the person is on some type of therapy, when they've been diagnosed with TB, sputum specimens are needed usually every 2 to 4 weeks once drug therapy has been started. When the results of 3 consecutive sputum cultures are negative, the patient is no longer infectious and may return to his former employment. Remind him or her to avoid exposure to any inhalation irritants because these can cause further lung damage, and that's what we're trying to minimize. Now, if your patient is in the hospital with active TB, he's placed on airborne precautions in a well-ventilated room that has at least 6 exchanges of fresh air per minute, and all healthcare workers must use personal respirators when caring for the patient. When hand and clothing contamination is a risk, use standard precautions with appropriate contact precautions, gowns and glove. In accordance with the Joint Commission's NPSGs, perform hand washing before and after patient's care. Precautions are then discontinued when the patient is no longer infectious, and that's important to know. So I just wanted to make that clear as to when we put them in isolation and when we can take them out. Okay. These are some other types of problems that you may see occur with your patient because obviously they involve the lung abscess. It's a localized area of lung destruction caused by liquefaction of necrosis, usually related to pyogenic bacteria and pleuritic chest pain. Okay. Usually antibiotics, if those don't clear up the problem, then you might want to drain the actual abscess. And sometimes our patients can have multiple abscesses and cavities that form in the patients with tuberculosis, for instance, or any type of other like fungal infections of the lung. And we see that more with people that maybe are so immunosuppressed, or even our patients that have AIDS. That's why it's important to, look at their history. Have they had, the flu in the past, maybe even pneumonia? Because usually with a lung abscess, that sputum will be have a particular color that may be very foul smelling, and that really could be indicative of a lung abscess. That's why too frequent mouth care for Candida albicans, so puts patients more at risk. I'm not going to worry about inhalation anthrax as there's no need to learn about Asian bird flu either. Pulmonary empyema is a collection of pus in the pleural space, most commonly caused by pulmonary infection, and this is one thing that we don't want to happen to our patients who develop pneumonia. Okay. And I'll show you where this would be at. See, for instance, this is where that infection or that pus would occur in that part of the anatomy of the lung in the pleural cavity. So that's pulmonary empyema. And there, if someone has an infection in other parts of the body, it can spread to the lungs by flow of infected lymphs into that pleural space. Sometimes chest surgery or trauma can introduce bacteria directly into the pleural space, leading to empyema, and blood from trauma may collect in the pleural space, promoting infection. So that's how we would see that begin to occur. You will see your patient really become very febrile. Always watch patients who have pneumonia. Say that chest x-ray is not clearing. Obviously, we're not clearing up the particular bacteria that's causing the pneumonia, and this is what we see happen. The patient develops empyema. They'll also have some chest pain, dyspnea, cough, and trauma. Obviously, look at the sputum. Also, the chest wall motion may be reduced. Fremitus may be reduced or absent, and listening to the patient's lung sounds. So a chest x-ray or CAT scan and a sample of the pleural fluid through a thoracentesis would be needed for a actual diagnosis. With empyema, the fluid is thick, opaque. It's an exudative and very foul smelling. So the fluid is analyzed for color, red blood cells, and white blood cells, glucose, protein, LDH, and pH. Many times we've got to see that the patient has this empyema removed so that you can have proper expansion of the lung. Appropriate antibiotics, sometimes a chest tube to close drainage to help promote lung expansion and drainage. And the tube will be finally removed when the lung is fully expanded and the infection is under control. If it's that bad, there is a possibility that a patient may need chest surgery if the pus is very thick or it has excessive pleural thickening. Okay, so that's what we would see. As I said, inhalation anthrax is a bacterial infection caused by gram-positive organism. Okay. We know that it's a rare natural occurrence in North America and it's not spread by person-to-person contact. It's very rare, so I probably won't even ask you anything on the test regarding anthrax. We always worried with anthrax that it was going to be a biological weapon in terrorism. It's fatally 100% fatal if untreated. And that's when a few years ago when, a lot of the rumors were that we were going to be threatened with a terrorist attack with the anthrax organism. And that's when the people who make ciprofloxacin really put out tons and tons of this drug to be able to be prepared if we were definitely attacked with such a horrendous type of bacteria. So we know it mostly comes from contaminated soil. There are two stages, the prodromal stage and the fulminant stage, and your book talks about that, of what kind of manifestations you would see in each of those stages, and how we would prophylaxisly and for the treatment of inhalation anthrax. And your book also talks about pertussis and coccidioidomycosis is a fungal infection caused by that particular organism that's very common in the desert southwest. But I'm not even going to ask about that. I think your book just gives you that information because it obviously is a respiratory problem. But I think we've covered this fairly well. And hopefully that helps. And the last thing I wanted to talk about was pulmonary embolism. And I'm just going to touch on it very casually because you'll get a lot more of this information when you get to 213 next semester in critical care. But the only reason I am bringing it up is because you are taught heparin protocol, and one of the reasons that you might see heparin initiated is with a pulmonary embolism. It is a collection of particulate matter, solids, liquids, or air that enters the venous circulation and lodges in the pulmonary vessels. In most people with pulmonary embolism, a blood clot from a deep vein thrombosis breaks loose from one of the veins in the legs or the pelvis, okay? A blood clot is probably the most common pulmonary embolus that you may see, and as you can see from this diagram, it depends on the size and to what vessel is involved with the pulmonary embolus, because you can see if it's in one of the big veins, your patient can have an infarcted area, just like we have an infarcted area in the heart. The same thing can happen in the pulmonary system. I think this is really important because we have all kinds of people that come into the hospital, and obviously the reason for prophylactic heparin sub-Q is to prevent any type of embolus from occurring, but you can see what people would be more at risk, and it would be anybody that has prolonged immobilization, and that makes sense, people that are laying in bed too long. That's why we give the heparin. People that have central venous catheters in too long, sometimes those can break off and cause pulmonary emboli. Any type of surgical procedures, we used to see that a lot with our patients who had coronary bypasses, or even, as I talked about, the laryngectomy and the radical neck surgery for somebody with cancer of the larynx. Those people would be at very high risk for developing pulmonary emboli. Obesity, advancing age, and conditions that increase blood clotting, or also if you have a history of thromboembolism, okay? Some of these patients could develop mild to very severe symptoms, which definitely impairs gas exchange. Your book talks about best practices for patient safety and quality care and how we can prevent PE. Getting people moving right away, ambulating them soon after surgery, using pneumatic compression stockings and even anti-embolism stockings, and evaluating the patient. Do they fit the criteria for the need for anticoagulant therapy? Avoiding the use of a lot of tight and constrictive clothing, preventing pressure under the popliteal space, and really assessing their peripheral circulation, checking their pulses, especially distally, popliteal, posttibial, pedal pulses. Moving people around in bed, refrain from massaging leg muscles, instructing people not to cross their legs. We give them the low-dose anticoagulants. And encourage smoking cessation. What do we see when our patients do develop pulmonary emboli? What kind of manifestations occur? And that's a great question. We see dyspnea, sometimes pleuritic chest pain, especially on inspiration, sharp stabbing chest pain, apprehension, restlessness, feelings of impending doom, cough. Sometimes that cough can show some hemoptysis, and they can be tachypneic, crackles, pleural friction rub, tachycardic, diaphoresis, fever, and petechiae over chest and axillary area. And of course it's going to be demonstrated in their arterial blood gases, where they start desatting and they have a decreased arterial oxygenation saturation. So I just want you to realize what kind of patients are at risk. We watch ABGs, AA gradient increase, pulse oximetry, imaging assessment, chest x-ray may show a P if it's large enough, spiral CT, TEE, especially for our patients who go into atrial fibrillation. Okay. Probably one of the most common types of diagnostic studies are that ventilation perfusion scan, or VQ scans. They're not, they do use them, but they're widely used. They're not as widely used, but may be considered in certain circumstances. Just be aware that your patient will have a diagnostic test to determine if they have an actual PE. Some of the other studies you may see is a BNP, a D-dimer. The D-dimer, a fibrin split product, will rise with fibrinolysis. Okay, so these are some of the blood work that will be done on your patient. Obviously, assessing their respiratory status. They may need oxygen therapy because these patients can become extremely and severely hypoxemic. Watching their vital signs. Drug therapy begins immediately with anticoagulants to prevent embolus enlargement and to prevent more clotting. Lovenox, unfractionated heparin, low molecular weight heparin. Enoxaparin, which is Lovenox, and Fondaparinux, which is Arixtra. It's usually used unless the PE is massive or occurs with hemodynamic instability. Looking at patients' PTT, and really we like it between 1.5 to 2.5 times. And this is why you were taught the heparin protocol, okay? And remember, heparin is one of those high alert medications, so it should always be checked with another RN, okay? There's a great chart in your book about drug and usual dosage to implement drug therapy for a patient with PE, heparin, enoxaparin, warfarin, and then and I'm not going to go over those, but it might be important to read those, okay? What kind of care do we give a person with pulmonary embolus? And there's a nice best practice chart on your book in page 606. And I'm not going to read all those. You're capable of doing that. So just remember the nursing assessments and care we give to a patient that may have a PE, and what we watch for when these patients are on anticoagulant therapy. Know the antidotes for some of your anticoagulating drugs. Some of your patients may need an embolectomy or an inferior vena cava interruption. Okay, so a lot of home care management as well as health teaching and health care resources. If they're on Coumadin and they go home on that, or if they go home, that the importance of coming in and having their INR done. Okay, so that's all you need to know from this slide. As far as from chapter 32 on care of critically ill patients with respiratory problems. PE is the only thing you need to know from that. All right, I know I've talked enough, and hopefully this helps in case we're unable to get through this in class tomorrow. So have a good night, and hopefully you'll be able to watch this in the upcoming week before your test. Thank you for your time and attention.